Hello and welcome to Coproduce Care. Today we have with us Andy Bell. Andy is the Deputy Chief Executive at the Charity Centre for Mental Health. He's been there since 2002, and in 2009 he became the Deputy Chief Executive. He's also a member of the Mental Health Policy Group and was the Chair of Mental Health Alliance. So welcome, Andy.
Thank you.
So Andy, you've done a lot for mental health in terms of research, in terms of your work with the Centre for Mental Health. Why is mental health so important to you?
So mental health is effectively about the way we live our lives. It's very much a social justice issue. We know there are huge inequalities, both in terms of the things that cause poor mental health and indeed the lives of people who are experiencing mental ill health. And the work of Centre for Mental Health is very much about addressing those inequalities head on and making a difference and doing research that really brings about change.
Great. And the centre has had a bit of changes. There's some new things coming up. There's a commission on equality or inequality. Can you talk a little bit about some of the new projects that are coming up for the centre?
Yeah, so the Commission for Equality in Mental Health is a major initiative that we began last year, and we brought together a group of people led by Liz Sace, who was the Chief Executive of Disability Rights UK and has a long and distinguished track record in supporting people's human rights and equality. And we wanted to ask the question, why is it that there are such stark and extreme inequalities, both in our chances of having poor mental health and also the experiences of people who are getting access to support or not getting access to support, and indeed the poor quality of care that sometimes people get from the same groups that have higher risks. So first of all, we wanted to understand why, but secondly, a lot of these inequalities have been known about for a very long time. So we wanted to look at solutions. We wanted to ask what needs to change. How do we put inequalities in mental health at the top of the policy agenda in mental health, rather than where they've tended to be over the last 2 decades, which is at the bottom? And so we wanted to change that. So by bringing together this group and by doing a lot of research into where these inequalities come from, what drives them, what perpetuates them, we're hoping that our report later this year will begin to provide some answers to what needs to change and how we can make that change happen.
And can we talk a little bit about these inequalities? Because you talk about them and you say that we've known them for a while. And I think, anyone who's involved in this type of work will know the different inequalities. But I think the way that the centre approaches inequalities in mental health is very holistic. So can you talk about the different types of inequalities that you're finding and some of the ones which are maybe more prevalent than others?
Yeah, so for example, we know right from the beginning of in childhood that if you're from one of the more deprived communities or households in this country, you're something like 4 times as likely than someone from one of the wealthiest before the age of 11 to experience serious mental health difficulties, and often multiple serious mental health difficulties. But we also know there are very significant inequalities in terms of race and ethnicity. So some ethnic groups have very much higher levels of poor mental health than average. We also know that people with disabilities, with autism, learning disability, hearing impairments, lots and lots of groups of people experience very much higher levels of mental ill health than normal, and not just a bit, a lot. We're talking about 3 or 4 times. So these inequalities are very stark. They undoubtedly have been around for a very long time, but in a sense, that's the problem. They've been around so long, people have almost accepted them as being what happens, as being inevitable. And what we want to do is challenge that idea that these inequalities are somehow just a natural part of life. And we want to look at what could change, what could help to really begin to kind of move things in the other direction.
I want to go back to these different inequalities. Obviously, there are so many, and you mentioned about across race, gender, poverty, wealth issue, age. The one about age, and especially with later life, is that an inequality that we don't normally talk about? We almost take it as a given that as you get older, then certain things will just happen in terms of maybe Alzheimer's or dementia that's more prevalent in later age. Is there an issue that we almost think it's inevitable rather than looking at why it might be happening to certain people?
Yeah, I think that's exactly what happens, and what we know is that people in later life, and indeed the deeper you get into later life, the higher the risk there is of having not just kind of the problems that come with old age, such as dementia, but depression particularly. It's very, very prevalent among people of pension age, and indeed people over 85. You have rates that are probably twice, if not more than twice, the population average. And people in residential and care homes as well have very high rates of depression. And what we hear consistently is that there is an assumption among health professionals, and maybe among all of us, that when you get older, you get depressed because you've got less mobility, you've got fewer social relationships potentially, you've got kind of less opportunities in life, and often quite serious physical health problems by that time. And so it's just taken as being something that happens. And I think that's really the gist of the issue, is that being old doesn't inevitably lead to depression, but when people do experience depression in later life, looking therapies can be just as effective as they are for younger people. They're just not routinely offered, and the problem isn't really kind of recognised as something which is amenable to intervention. And yet again, the things that tend to work are remarkably low cost, low tech solutions.
So what type of solutions are good for that age group in terms of depression, or people in care homes, as you mentioned?
So some of it is about providing particularly talking therapies, so cognitive behavioural therapy, but it's also about things you can do to prevent mental ill health, of course, because again, mental health problems are best prevented where possible, and then treated where necessary as quickly as you can. Things like social prescribing initiatives, which are becoming more popular. Some people like the term social prescribing, others don't. But in terms of giving people opportunities to be involved in social activities of their choice, of physical activities, we know these can have a significant effect on both reducing the likelihood of having depression, but also as part of a route to recovery.
So there's almost a little bit of a need for people who are looking after older people, if you're looking at that specific group, to think about what might be helpful for that group outside of just looking after them for their immediate need, which might be personal care, looking at the wider, the social and mental health issues that help by being in a community or doing certain activities that help with mental health. Do you think that with some of the other inequalities, that it's more around not just dealing with somebody because of their gender or their race, or thinking about how the problems might be outside of their immediate situation? It might be social, or in terms of all of these different inequalities almost being caused by the same sort of thing. Is there a link between poverty and gender, and poverty and race? Or they are quite distinct in the way that the inequalities in mental health apply to them?
I think the evidence is telling us that they are inextricably linked. And one of the things we've done traditionally is looked at different inequality issues separately. So there's been a focus on race, for example. There's been a focus on gender, and there have been kind of lots of reports that have taken a single inequality dimension and talked about what the problems are, and explained very clearly why there are higher rates among some groups of people. But inevitably that misses the overlaps and the multiple layers of identity and experience that actually affect individuals and communities. So we know, for example, that multi-ethnic groups that have higher levels of being detained under the Mental Health Act, being sectioned, you tend to see they're the groups that are people that are also generally poorer and have poorer outcomes in other areas of life. We don't have good data that compares gender and ethnicity in terms of use of the Mental Health Act, which is a dreadful gap in what we've chosen to collect data on traditionally. And again, I think that tells us that we don't pay enough attention to some of these overlaps between factors to the extent that we simply, nobody's bothered to go and find out. And so I think we fundamentally know that if you only take a single dimension of someone's identity or experience, you're always going to miss what's really going on for them.
So it's almost the way that we're collecting data isn't helpful in the way that we are then developing our solutions, because if we're looking at the wrong type of data, we're potentially going to have the wrong type of policies. Is the centre doing anything then through the new commission to look at the ways that we collect data and the way that we are creating solutions based on different types of ways of looking at what the data is telling us?
That's what we're in the process of doing. So it's worth saying that this commission is in the process of looking at what the solutions might be. And inevitably, the way data is collected and what we choose to collect data about is part of that. But we also are looking at why it is that wider social inequalities do affect people's mental health and what can be done about those. So particularly why inequalities in wealth seem to have such an extraordinary effect on people's mental health and well-being. So we're going to be looking at a range of solutions, everything from what can feel a rather dry topic of the way data is collected, right the way through to what's happening in communities where there are initiatives that are really beginning to change things for people that come from communities, and indeed what needs to change in national policy as well. So we know that policies around social security, around criminal justice, around education, they have a huge effect on people's mental health, probably more than health policies do, and yet they're very rarely looked at for their mental health implications. So one of the things we're looking at is what would happen if you put mental health into all areas of government policy. And what kind of policies would you end up with, and how could we, through that broader approach, begin to reduce some of these inequalities at the kind of end of prevention rather than waiting for them to happen.
So that's really interesting, because we've talked before about this holistic approach that the centre's taking, especially that you've talked about in terms of looking at mental health, and you've talked about from childhood right the way through the system. What are the surprising statistics or pieces of research that you found led you to see the system in the way that you do at the moment, seeing it in such a holistic way from childhood right the way through, whether it's through the penal system, through the way that we treat people in care, all the way through the different systems that we have?
So I think one of the things that we found, again, being an independent organisation, it means that we can look at the problems that we identify and do that without fear or favour, or indeed any political agenda. And so, for example, when we've looked at the mental health of people in the criminal justice system, particularly in prison, what's really noticeable about people who find themselves there is the vast majority have not just got mental health problems at the time, some of which are related to being in prison, but many had mental health difficulties throughout their lives and going into early childhood. Many also had various bits of contact with mental health services, both as children and adults. That never really went anywhere. But again, you also see a lot of involvement in the care system. You see school exclusion and very negative experiences of the education system, and often people whose families have struggled with managing behaviour, for example. And so it's very, very obvious that when you look at one bit, you're inevitably pushed to look at another, and particularly when you look at mental health difficulties in adult life, you're really looking at what's happened earlier. And I think we really need to understand that our mental health is shaped from our very early experiences in life. And there are things that we can offer to people of any age, whether you're 5 or 85, that can help your mental health. It can give you a better chance of having good mental health. We just don't often take those opportunities. We wait for a crisis. We wait for someone to end up in a situation where they have to go to A&E or they get picked up by the police. And that's looking at things in a very unhelpful way. Obviously, when people hit crisis, you need really, really good crisis services. But what we don't do is have those preventative services available at scale. So I think it's about following the evidence and really understanding people's journeys and experiences and narratives, rather than just what perhaps has traditionally happened, where people with a mental health difficulty have just been seen as someone who needs to be fixed, often with medication.
So there's very much a focus on prevention. But what would you say to someone who has the argument of, well, this is potentially quite a lot of money to be spending on preventing something that may or may not happen?
So put simply, the economics of prevention are really good. Prevention activities tend to be really inexpensive, and you can often do them at scale.
Yeah.
So for example, teaching children about mental health in school is known to have a really good preventative effect, and it's basically doing it as part of the school day. Evidence-based parenting programs that support parents with young kids, many of whom really, really want help in how to kind of support their children's behaviour and how to be good, positive parents. They're largely not offered, but these are very, very inexpensive compared to the costs of what happens if you don't intervene early. So as long as you're kind of doing evidence-based approaches to prevention and following what we know seems to work and seems to have the best effect. These are relatively small numbers in terms of funding, but they can make a very, very big difference both to people's quality of life and also to public sector budgets across the whole system later.
You seem to have such a good model developing there. So you've got interventions which are preventative, which are not very expensive. You've got something that looks at the whole person, so people's journey that starts right at childhood. How do you feel that you might have an impact with this potential solution, evidence-based information that the Centre for Mental Health is collating? Is there any way of connecting with government to have those reports that you put out, to have all of the information that you're collating now fed into policy? Do you feel like your voice is being heard in all of this?
Inevitably, it takes time. I think there's sometimes been an assumption that if you produce a good, worthy report and it has sensible recommendations, that those will find their way into policy. They don't unless you work hard to make it so. And so one of the things we do as an organisation is work with policymakers, work with people in both local as well as national government. There's an awful lot here that local government does.
Right.
And sadly, they've had very little funding over the last few years, and they've experienced successive reductions. But a lot of the really exciting work is happening in locals, in communities, often in conjunction with local councils that are really getting mental health and understanding the opportunity they have to make change locally. But of course, we also work with government, we work with civil servants and ministers and really anyone who will listen. And if people won't listen, then we find a different way of saying it until they will. And one of the really important things about research is making sure that that is put forward in a way which is understandable and relevant to people making decisions about how public services are run, where money goes. And it's not easy. And sometimes it takes time to make that change. But I think we've got a really clear case for action. And I think there are now lots and lots of voices, not just other mental health organisations, but lots and lots of people who are now beginning to make their voice heard. Particularly, I think people with lived experience of mental ill health who are not prepared to take no for an answer anymore, and quite rightly so.
And what about if people want to get involved with some of the work that you're doing? You're talking about looking at seeing how local groups, community groups are providing outcomes. How can they get involved with the work that you're doing?
So we're really interested in particularly local initiatives where there are groups, organisations, community-led organisations, it doesn't matter what it is, that are making a difference to people's mental health. If you've got something that you want to share, particularly where it's tackling inequalities and supporting groups who otherwise have very poor experiences, tell us about it. Get in touch on Twitter, send us information through our website, tell us about what you're doing and share the exciting innovative practice that's going on. That's how we know about stuff. But we also, of course, are providing research. We're providing tools that we hope people will find useful locally, that summarises some of those research in nice, easy and short bites that we hope people will make use of when making the case to their local powers that be. So do use our stuff, come on our website, have a look at our Twitter and other social media, and the more voices who are making this case, the better.
Great. And I think I would also second that people get involved, because the work that you're doing is so interesting and very exciting in terms of looking at mental health from a different lens. You've also written something about the NHS long-term plan in 2019 last year. So that potentially would give money into the system. So it's pledging to invest, I think, about 2.3 billion over 5 years. And that would largely go to community mental health services and changing the way that they kind of radically overhauling the system with community mental health teams as they are at the moment changing. Can you talk a little bit about the plan and whether you think that it actually goes far enough?
Yeah, so the NHS long-term plan on mental health is, I think, one of the strongest national plans we've ever had. It's certainly got the largest amount of money that's ever been invested in one go in mental health services. And I think it's really important that it's addressing the fact that we've all known for far too long that community mental health services in particular have been under-resourced, underfunded, struggling to keep up with what's a very clear growth in the number of people asking for help for their mental health. And so I think there is a huge amount in that plan that's really welcome. The fact that there is actually proper money going into community teams that support the vast majority of people. There's an assumption that when we're talking about mental health services, we often mean hospitals and beds, and a lot of the debate is about that. What we know is that the vast majority of people getting help for their mental health are not using hospital services, not inpatients. They're people living in their own homes, living in communities, who are getting support from teams of people who come to them. And that seems the most effective model for most. There's also a lot of demand for help in primary care, and indeed lots of people who get help for their mental health will never go near a specialist service. They'll get everything from their GP or from talking therapy services. So I think the long-term plan has enormous potential. The biggest issue inevitably will be how we get people to come and work in those services, because that £2.3 billion, most of it will be spent on people, helping other people. That's what mental health care is. There's very little that's high tech. And that means we need to have an unprecedented expansion in the mental health workforce, in nursing, in psychiatry, in social work, in occupational therapy, in peer support, in all of the types of intervention that are needed, psychology, psychotherapy. They all have an important part to play. And the challenge for the NHS will be both to increase the number of people coming and working in mental health, but also to allow people to build careers and to work in workplaces that are flexible and healthy and supportive, so that we can build this workforce up and meet the potential that the long-term plan sets out. I think the difficulty in a way with the NHS long-term plan is that it's an NHS long-term plan.
Yeah.
And a lot of the really important areas of mental health support come from local government. And as I said, we've seen successive cuts in local authority funding. Particularly social care is under enormous pressure. Public health services that prevent problems in the first place have experienced one reduction in funding after another. Local government commissions drug and alcohol services, and there's a huge overlap for mental health and substance misuse. And indeed, local government's also responsible for things like housing, which is terribly important and often the most important part of anyone's support who particularly is vulnerable or at risk of being homeless. So the NHS long-term plan is the health service doing its bit. We now need to make sure that other parts of the system are properly supported by government to do their part. Otherwise, we're simply creating a more and more unbalanced system where we're more and more reliant on NHS to deal with problems that could have been dealt with earlier at very much lower cost and avoiding an awful lot of unnecessary suffering.
Is there a bit of an issue with what's been termed parity of esteem in terms of mental health, seeing mental health as just as important as if you had a broken leg and seeing it as a health problem, like you would see something in the NHS, and the idea of NHS and social care or health and care having the same footing in terms of attention in the media and funding, and seeing social care, which is where a lot of the mental health support comes in, especially from local authorities, seeing that just as important. Do we need to just change the narrative as well of how we see what the amazing work that's being done in mental health services in social care, so it's seen at the same level as we would approach certain services in health?
I think in terms of parity of esteem for mental health with physical health, we're getting there, and we're on a journey, and it's a long journey, and we all wish it was quicker, but we're making progress. I think you're right when we think about how much we value social care compared to healthcare. We're nowhere near valuing it equally or fairly, or indeed seeing the value that social care and social work offers in mental health. And I think mental health social work is very different also to other areas of social care. It has a very unique and important role that is very seldom valued either in the kind of mainstream debate about social care, where most of the debate is about services for people in later life, nor is it valued in the NHS as much as it should be. And I think that we're beginning to kind of get a recognition now from people in the NHS that the lack of a fair funding settlement for social care is actually the main thing holding the health service back from being able to fulfil its potential. And so I think there is a recognition now that fairer funding is needed, but I don't think there's yet that same kind of political impetus and pressure for that to happen.
I think that's a really good point in thinking that mental health is actually a very niche part of social care as well, because when I go to conferences or I talk to people about the green paper or the social care, the conversation often mainly focuses on care homes or older people services and how we're going to fund and support those. And people do rarely talk about mental health services for younger adults. So that probably won't offer anything for the area that you're working in mental health. So we've got a new Minister for Care.
Yeah, Helen Whately, yeah.
What would you be asking her to concentrate on?
So I think fundamentally, first of all, we need to ensure that government said it wants to sort out the funding of social care and come up with a sustainable settlement that deals with this for the long term. And we think that that's an incredibly important thing to do. And in doing that, we need the Minister and her advisors to think about how that's done in a way which supports people of working age as well as people in later life, and that particularly responds to the needs of people who get social care support for their mental health. And I think alongside that, we really need to look at the workforce. So the government commissioned a review of the Mental Health Act, which reported in 2018. And one of the recommendations for that was that we need to invest in the workforce in social care, in local government, to make sure that people's rights are safeguarded more effectively than they are now. Particularly thinking about the role of approved mental health professionals, most of whom are still social workers, even mental health advocates as well, who provide an important and barely recognised safeguard of people's human rights. And so if we're going to invest in that, we also need to think, while we're building up the health workforce, about how we build up the social care workforce and advocacy. And again, these are far less valued than things like nursing or medicine. And yet we know that they provide an absolutely vital function in the system. So I think build a fair funding settlement that works for mental health as well as other areas in social care, and really start to look at how we can build up the workforce.
Yeah, I think a lot of people would agree with that, because especially when you're thinking about the long-term plan, the NHS long-term plan for mental health, and that money that you were talking about, how is it going to support that workforce? There's a whole different conversation to be had about outside of the NHS, the workforce that's going to support people with mental health difficulties. So yeah, I think that's an interesting proposition, really. I think we're pretty much coming to the end of this part of the conversation, but I did want to ask a little bit about the National Health Service, if I can. So yep. I obviously just having a look and seeing what you've been involved with, and nationalhealthservice.net has got some articles which I think are mainly about mental health. And you've written for them a little bit as well. Can you talk a little bit about that blog, podcast, and the organisation that is?
Yeah, so we're very lucky to link up with mental health, as it's called in the mental health side, and the fantastic work that Andre Tomlin has done to, I think, first of all, to create a place that people can go to get honest and sensible digests of recent research, but also to kind of pick up some of the key issues that are around in mental health at the moment and create debate. So one of the things that they do, for example, is they go to events and they live tweet, and they provide blogs and podcasts from events which help get the message way out beyond the room that those people are in, which first of all is all about democratizing the knowledge that's there in those places. And secondly, about reinforcing the impact. And so one of the things that we're very fortunate about is that we host a campaign called Equally Well, which is about improving physical health for people with a severe mental illness. And we've been really lucky that the National Health Service have helped us in terms of getting that message out, sharing some of the insights that we've got from people with both personal and professional experience of the issues.
It sounds like a really good organisation. I definitely want to look at some of their work and maybe ask them to come on a Coproduce Care Chat, because it's a similar type of thing that we're trying to do, is to get those conversations out to a wider audience. So it sounds like some really good work. One other thing I wanted to ask about was the idea of institutionalization. So these mental health institutions that we have, the psychiatric hospitals. I was speaking to Bethany's dad. So Jez, he's got his daughter has autism, and she spent a lot of time in mental health institutions which haven't been really helping her at all. And he's fought really hard to change her situation and improve it to a different type of care package. And one of the things that happened, one of the experiences he talks about was when she was very frustrated, and I think she had a pen and she basically inserted it into her arm, and the staff at the hospital said, well, she's too dangerous for us to seek medical help for her. So they didn't do anything for her for a while. And you do tend to hear what I would call horror stories in some of these institutions. From what you've researched, I don't know if you've done much research around mental health institutions in particular, but do you find that do they help people, or are they actually not helpful for the people that they are looking after?
This isn't something that we've looked at specifically, particularly in terms of quality of care, and indeed the very particular needs of both children and young people and adults with autism and severe learning disability, who find themselves detained under the Mental Health Act in hospitals, often for very prolonged periods. And I think we know that this is a really important issue that the review of the Mental Health Act, for example, had to grapple with. And when government comes to legislate on that, they're going to have to really start to look at it. But I think also we know that, I mean, it was back in 2015 that the coalition government put out a plan for transforming care, which has been very, very slow since to be implemented. And so there are some really serious issues here that need to be addressed. I think what we know overall in the mental health system is first of all that inpatient services, they do have an important role in the system for some people. But an inpatient stay can be a frightening experience. It can be a traumatic experience. It can sometimes lead, particularly if people are in hospital for prolonged periods and particularly away from their home area, to a real loss of connection back home and a loss of confidence in living independently. And very often we see people who spend far longer in hospital than they should because there isn't a package of support available back home. And again, this is where social care and housing are just as important as healthcare. So there are some really, really serious issues underlining this. And I think what Bethany's dad and others have done is drawn everyone's attention to the fact that this has been swept under the carpet, left to the margins of policy, and thankfully now I think it is on people's minds, and we've really got to act on that and see some progress happen and really understand what are the solutions. And as ever in mental health, the solutions often come from understanding from people's lived experience what they need and what they would find helpful. And starting with that rather than a kind of old-fashioned paternalistic approach that professionals always know best.
Yeah, and I think that's a really important point, to start from people's lived experiences and work outwards rather than the other way around, which I feel that the Commission for Equality in Mental Health will be focusing on. I think that's everything really for this Coproduce Care Chat. If people do want to get involved with some of the work that you do, and someone did ask about how do service users join the Equally Well. Is there an Equally Well programme? I don't know if that rings a bell with anything.
It definitely does. So Equally Well is our collaborative campaign that we host with lots of other organisations, which is all about addressing why it is that people with long-term mental health problems have very much reduced life expectancy compared to average, and what we can do to change that. So we really want people to be involved in Equally Well. It's about building a collaborative of organisations, whether they're in health, social care, housing, education, who have a part to play in about a more equal health system for people with a mental illness, so that we don't see people's physical health needs being neglected because they're being treated for a mental health problem. So in terms of individuals, we have the support of Rethink Mental Illness, who are an amazing charity, who one of the many things they do is coordinate a group of people who are experts by experience, and so that's a really good opportunity for anyone who wants to be involved. But we also are encouraging organisations to sign up and to make a pledge for what they're going to do within their powers to bring about more equal health for someone with a mental illness. So whatever organisation you're working for, if you've got a part to play in that, get your organisation to sign up to Equally Well. You can find a charter for Equal Health on our website, equallywell.co.uk. Get involved, make your pledge, and become part of the movement.
That sounds great. And I think I'm going to be looking at that website as well. We'll put it in the notes of this podcast for anyone who's interested. And also we'll put a link to the website for the Centre of Mental Health and the reports that are on there. So thank you very much, Andy, for joining us. So Andy Bell, Deputy Chief Executive at the Centre for Mental Health. Thank you so much. There's a lot that's, I'm sure, going to come out from this call in terms of following up all of the reports that you're doing and the great work. So good luck with it all. And hopefully maybe we can have you on again in a year's time or so to see how you're all getting on.
Thank you very much. And I look forward to working with you on this and lots of other things. And thanks for your time.
Yeah, thank you.